Living in Virginia, you're in the fast lane on the information superhighway. We've invested $3 billion in Virginia's broadband network to give you one of the fastest internet connection speeds in the world, so you can build relationships, bring new business to our state, and meet the future of education. It's amazing what we can do together. Visit VCTA.com to learn how broadband connects the Commonwealth.
From the General Assembly and the City of Richmond, I'm Woody Evans for Cable Reports, brought to you by the VCTA Broadband Association, connecting Virginians to their government. We're real pleased to have the Secretary of Health and Human Resources with us today, Dr. Daniel Cary. Welcome, sir.
Well, good morning, and it's a pleasure to be with you, Woody.
Can you give us a brief health of the Commonwealth, so to speak?
Sure. I think in general, Virginia has a tremendous and resilient healthcare system. We are blessed with world-class academic medical centers. We have excellent health systems throughout the Commonwealth, Southwest, in the North, in the Valley, down in Tidewater, here in Richmond, as well as in Northern Virginia. I think we have some of the world-class treatments for cardiovascular disease, for cancer treatment, neurosciences, pediatrics. So the healthcare system in Virginia is excellent. It's not perfect everywhere, and I think that's one of the things we are working on, is to spread those services across the Commonwealth in a more equitable way. So I think the health of the Commonwealth is solid. I think one of the real gaps in the Commonwealth is similar to the gaps across the country. Mm-hmm. It's access to insurance that pays for high quality care. And that has really been one of the governor's principal policy programs to build on our success with the General Assembly in expanding Medicaid. Now 385,000 Virginians, mostly single adults, but many parents in the Commonwealth since the beginning of 2019. So a tremendous success in covering more Virginians with insurance that covers the services they need, whether it's cancer drugs or needing a bypass operation or whatever that ailment is, that is covered. So we've done a good job together with the General Assembly, but we've got more work to do. Again, having great services available in the Commonwealth is not nearly as does not have the impact if many Virginians don't have insurance, they don't have the coverage, and they can't access that care when and where they need it.
How difficult is it for people to access the exchange? I know now there is a federal exchange. I understand one of the governor's initiatives is to create a state exchange. That's exactly right. With the passage of the Affordable Care Act a number of years ago under President Obama, it created either the states had an option to create their own exchange, or there was also a federal exchange. And what really this is a virtual marketplace, not a store or a mall that you go to, but it acts like that, where you go online or you go through a broker, and there's a number, and this is for the individual market. Again, many of us have our insurance through our employment, but many low-income Virginians don't have access as a benefit through employment. Some of us have it through the government. Either they're retired military or they're over 65 and are covered by Medicare. But there's a large group, many of which do not have access to high quality, affordable insurance. They get insurance now in what is called the exchange. Now, when that started, there was a number of elements that there was funding from the federal level to work on outreach to. Maybe it's the Latino community or the African American community, or it's the rural community that need information and they need outreach to make sure that they understand what the programs are. And over the last 4 or 5 years, those funds to cover outreach, to cover reinsurance, to cover another of risk sharing have been cut at the federal level. And what that has done is lowered the number of people that get their insurance in the exchange, and that has made the prices go up for premiums that are almost $800 a month for an individual, and which for many Virginia families is simply unaffordable. So the whole idea behind creating a state-based exchange is that you actually run it yourself, although with the help of vendors that do most of the blocking and tackling, if you will, but it's managed and governed by the state. And the advantage is that you have access to the data. Mm-hmm. We get data right now from let's say 2018, there were 300,000 or 400,000 individuals, Virginians, that got their insurance in the exchange, but we didn't know exactly who they were. The federal government does not share that in real time. You get aggregated data after about 9 months. If you have a state-based exchange, you know that's Mrs. Smith or that's Mr. Jones. And there are subsidies on the exchange for the group that is above the 138% of the federal poverty level, that is the upper limit of the now Medicaid expansion. For those for 139, up to 400% of the federal poverty level, which in places like Northern Virginia and in the middle of Virginia Beach is not a lot of income, and can you afford groceries and housing and transportation, all of those things. So what a state-based exchange does is allow us to manage the individuals in real time. Are they eligible for Medicaid? Let's do outreach to them. Are they eligible for the exchange with subsidies? Are they no longer in the exchange? Did they get a job that now has health insurance as a benefit, which is a great thing. We want everyone to get more skills and to get great jobs that have benefits like insurance. But there's still going to be a subset of Virginians that have trouble finding insurance. And if we create a state-based exchange, that will make it a lot easier for more families. And also, we can do plan design that's more attractive to individuals. You can do trials of particular plan designs at the state level that you can't simply do at the federal level. So I know I've gotten into the details there, but I think there's some important distinctions. So I think that is part of the governor's overall plan. Now that we've covered almost 400,000 people in Virginia under Medicaid expansion, how can we move up the income level and make sure that insurance remains affordable? If you have, and that's a good time. This is a good time to maybe to also indicate other elements of the governor's agenda when it comes to insurance. Is these things that are called short-term limited duration plans that the president has been pushing, and one of the President Trump has been pushing. The problem with these is that they were not designed to be quality insurance. They were designed to be a bridge for people who lost a job and are getting ready for another job. They tend to be less expensive because they cover many fewer things. So one of the principles that the governor is very committed to is that if you have insurance, it should cover the core set of problems that people face. Otherwise, it doesn't provide the medical care you need, and it doesn't protect you from financial disaster. Because we all have relatives that had a heart attack or had a cancer diagnosis, and they did not have high quality insurance, and they lost their house, they lost their farm, and they lost their health because they eventually lost access. That's a terrible thing, and that's wrong. So the governor's agenda, really, building on Medicaid expansion, is to fortify the individual market. So, and part of that is to make sure people, from a truth in advertising perspective and consumer protection perspective, that there aren't these flimsy plans masquerading as insurance. So our agenda is to keep those short-term plans exactly that, short-term.
Now, the governor has a significant emphasis on maternal health care and child health care. Talk to us about those two issues.
Sure, very, very important, and thank you, Woody, for bringing those up. One thing the governor feels very strongly about addressing, and is something that is not true just here in Virginia, but across the country, and that is a significant inequity in maternal mortality. That means during pregnancy, around the time of delivery, or in the year after delivery, what's the likelihood of a mom dying? It's a relatively rare event, but a very important event, obviously. In Virginia, if you're an African American woman, your risk of dying in that period is 2 to 3 times what it is for a white woman.
2 to 3 times.
2 to 3 times. Now, there's a variety of causes of that, and some of the causes we don't fully understand, but access to insurance is part of it. Also, there are some low-tech, high-touch ways to support women and navigate them to services. Also, it's access to food, it's access to shelter, it's a safe place to live, it's transportation to and from doctors' offices. So the governor last spring put a flag in the ground and said, that's not right, it's really unconscionable, and we need to address it. And his goal is to eliminate that inequity by 2025. And let's talk about how he plans to accomplish that. First is there's the group that, one is Medicaid expansion. All those women, up to 138% of Medicaid, that used to lose their insurance 2 months, 60 days after delivery, now have insurance continuously as long as they're eligible. There's the group that has access to Medicaid when you're pregnant from 139 up to 205% of the federal poverty level. That group loses their insurance 60 days after delivery. And what we've realized from the data here in Virginia is that over 60% of the women who die do so beyond 6 weeks. So normally or typically the focus is on the infant, the focus is on the baby. But guess what? Mom has high blood pressure. Guess what? Mom may have obesity and obesity-related illness. Mom may have diabetes. Mom may have asthma. And as you get further from delivery, unless mom has access to healthcare, access to the medicine she needs, she's much more likely to have serious complications from her illness. And that leads to that mortality. So that is part of the governor's introduced budget. We also have pilot programs with doulas. Doulas are assistants.
D-O-U-L-A.
D-O-U-L-A, right, exactly. And the focus with doulas, and in this case birth doulas, there are doulas that work with people at the end of life when they have a serious illness. So it's the point is there's someone around to focus not on the medical care, not on the medical condition, but on the individual, what she needs in this case around delivery, to make sure that her voice is heard. We went around the state. We had 10 maternal listening sessions in the fall, and the team from Health and Human Resources, together with members of the General Assembly and stakeholders across the Commonwealth, and listened to the experience that women, especially women of color in Virginia, had as they navigated the healthcare system, as they were pregnant and received care or didn't receive care, as they were respected or not respected, as they were listened to or not listened to across that care experience. And we learned a lot. And I can say as a physician, I didn't always hear what I wanted to hear, but gosh, as a public servant, I heard what I needed to hear. And that really has informed the governor's agenda to meet women, especially women of color, where she is, where her family is, and what those needs really are. So the agenda is around doulas to support women at the time of delivery and later on to make sure mom is doing well, that her health is supported in addition to the baby's. And also, we mentioned expanding Medicaid in those women that are eligible because they're pregnant out to a full year. And lastly, home visiting. The home visiting when professionals, whether peer specialists or visiting nurses or folks that are even social workers, a number of community health worker model where folks are trusted members of the community, from the community, go and meet with women before birth, around the time of birth, and after birth to help navigate them through this very complex healthcare and social service system we have, not just in Virginia, but across the country. But that support in models here in Virginia, like Urban Baby Beginnings, like the Motherhood Collective, like a number of other programs around the Commonwealth, have shown to decrease maternal mortality and also lead to healthier deliveries and healthier babies. And we've seen that in models in other states. So we're exploring whether Medicaid and other insurances should be covering those services, home visiting as well as doula services around the time of birth. So we're really excited about it. In terms of children's health, we're really excited about an initiative that really has been championed by Pam Northam, the first Lady of Virginia, and making sure that we call it -9 to 5. In fact, there's a group down in Tidewater called that -9, meaning at the time of conception through 5 years old, how important that is to focus on that early development, that early brain development, and that young family that's trying to nurture this individual. So there's a program to integrate early childhood education and early childhood care, to braid different funding sources to make sure that families and young children in Virginia get the start that they need. Tremendously important.
And it's a real holistic approach, as you point out. Housing is very important. Obviously, early childhood education married with this initiative to help younger children in terms of their health needs. Improves their health, improves their ability to succeed in school and thereafter.
I couldn't agree more. And I think that there's a term in public health called the social determinants of health. And we realize that if the issue is access to transportation, access to a safe house or apartment that doesn't have mold, doesn't have fraying insulation that exacerbates someone's asthma or a child's asthma, if they don't have transportation so they can get to their job, if they don't have access to nutritious food, all of those elements are critically important to help individuals live a safe, healthy, and successful life. And I would say that's one of the governor's most important principles, is that every Virginian, especially every child, deserves a shot at a safe, healthy, and successful life. And that means we have a core set of services, whether it's early childhood, and what the end of that program is making sure that 3- and 4-year-olds in Virginia, that there's quality education, and it's not child care, it's child care and education to get that great start. And it's probably related to the governor's focus on behavioral health, which is one of the additional very important initiatives. In the past several years, STEP Virginia, System Transformation, Excellence and Performance, is a strategy to make sure that all 40 community service boards distributed relatively evenly throughout Virginia by population provide a core set of behavioral health services. And in prior years, we've started the first 2 or 2.5 steps of STEP Virginia, same-day access, for example, and medical assessment. But there is a number of other services for veterans and a number of other elements that make for the safety net of behavioral health that helps stabilize individuals in crisis across Virginia. So part of the governor's agenda is to build that out. Not all the steps in the governor's introduced plan, but all but 3 of those 10 steps to be funded in the next biennial budget. Very, very important. Also to deal with the temporary detention order crisis that we have in Virginia, just access to when individuals are in crisis and they're a danger to themselves and others because of a psychiatric condition, a behavioral health condition, we need to stabilize them. And right now there's a real shortage of places where they can get that care. Yes, it's in the private system, but the capacity isn't what it needs to be. And that has led to overflow into the state system that really was designed for folks with serious mental illness that need longer term stays. So we're trying to work out with the General Assembly how best to create capacity in the community and also how to stabilize people without the need for psychiatric hospitalization. And so that's a very important initiative.
What about the opioid crisis? I'm sure you're still dealing with that.
It's yes, we are. In many ways, it looked like the number of deaths from opioid overdose had flattened, and it has tailed off, but it's nowhere back where it needs to be. In fact, We want no one to die from an overdose, whether it's opioids or methamphetamine or cocaine in the Commonwealth. And we have to remember that addiction is a disease. It's a chronic, relapsing brain disease. It's not a moral failing. It's a medical condition, and we need to treat it as such. And that's an important part of the governor's perspective in our agenda around opioids. Well, on the upside, under Medicaid, there's a collection of services called the Addiction Recovery and Treatment Services that really is a model for the country of the full continuum of care, from an outpatient model to acute detoxification on an inpatient basis, and all the appropriate levels in between. And we've definitely seen progress in access. In 2019, over 20,000 individuals in the expansion population received services for substance use disorder. And in addition, we realized that we're trying to go down the stairs, but the stairs are not really stairs, they're really an escalator because of fentanyl.
Yes.
Fentanyl is much more potent than heroin and other opioids, and carfentanil is 100 times more potent than fentanyl. And what an individual who does have substance use disorder, especially opioid use disorder, and is not yet in recovery and is using illicit drugs, she or he does not know what the percentage of fentanyl. Mm-hmm. And the problem with fentanyl is that it's so potent that it stops an individual from breathing, and that's how that individual passes away.
I take it the use of naloxone has helped in terms of avoiding deaths, at least.
It has, and one of our policies that we want to continue and spread is to get naloxone wherever people are, in schools, in public places, in libraries, with school nurses, with in the work site, in first responders, so that with either an injection in a muscle or with spray in the nose, that someone can be revived. Really, it's remarkable. I remember over 30 years ago giving naloxone in an emergency room to someone who we thought had already passed away, and he woke up within 20 seconds. It binds to the opioid receptors, not just in the brain but around the body, and displaces it, and it very quickly reverses the effect of opioids. So having that out in the community, and I think you've touched on an important point, that underlies this, is that we need to get rid of the stigma. Mm-hmm. It's a chronic relapsing brain disease, and the stigma of substance use disorder or addiction, we need to fight that, because that means people aren't seeking help, and also the loved ones around them don't have things like naloxone to help keep people safe. And individuals don't carry naloxone. Now that has started to change. And in the introduced budget, the governor has recommended millions of additional dollars to make it easier and cheaper to provide naloxone through local health departments to everyone who needs it, and everyone who has a loved one that may be at risk of relapsing and dying from an opioid overdose. I will say that one of the most important steps is local coalition development. And we've seen in towns like Lynchburg and Roanoke and Hampton and in Winchester and here in Richmond, law enforcement, public health, behavioral health, the medical systems, the federally qualified health clinics have come together to design what are the opportunities in their community to reach people that are really, again, it's a disease of isolation and desperation. So its connection is the real antidote to addiction and substance use disorder. So that's the work that we're seeing around the Commonwealth, and I'm very inspired by that, but we still have a long way to go.
So how significant is the risk of e-cigarettes, especially to our students in our high schools?
Well, I think that vaping has become a significant risk. One for a variety of reasons. First, we don't know fully the effect of nicotine on the developing brain. So children and adolescents, that smoking has gone down in the Commonwealth of tobacco, of cigarettes, but vaping has gone up. And the Virginia Foundation for Healthy Youth is doing a great job working on decreasing youth smoking and now decreasing youth vaping. So I think the real problem is that we don't know the impact on nicotine on the developing brain, and it's a powerful stimulant and it is addictive. So that I think, again, eliminating use of vaping in youth is critically important. So I think that for adults and older folks, there is some literature that nicotine delivery devices like nicotine gum, like nicotine patches, and nicotine vaping has been shown to decrease tobacco use. That's a little bit controversial, but that's not what we're talking about with youth who become addicted and are more likely to move from vaping to tobacco products. So there is no safe, entirely safe vaping product. And we also should point out that some of the illicit vaping products that had THC, the chemical that within marijuana that leads to intoxication, that there was a vitamin E acetate, which is a very thick and viscous substance, was leading to lung burns, and those deaths, the vaping related deaths across the country and lung injury are related to vaping. So I think that we need to, there is no safe cigarette, and from my perspective, there is no safe nicotine product, and I think we need to address it with that perspective.
Got a couple of minutes left. I wanted you to give us a view of the problem of surprise billing, number one, and the continued high cost of prescription drugs.
Wow, those are big topics. I will say first, surprise billing is a big problem, and we're seeing a number of bills in the General Assembly this year to address that. Last year, the General Assembly asked the Secretary of Health and Human Resources, our team, to put together a work group, and frankly, we were not able to find a consensus solution, whether it was between the provider side, which is the doctors as well as the health systems, or the insurance side, but there's also the patient and consumer advocate side. So a lot of different perspectives. And at some point, we got to give a little to get to a better place. And the typical situation is in an emergency, someone is taken to a hospital, and obviously if you're in a car wreck, or God forbid you're in a bike accident, or you're having a heart attack or a problem with your breathing, you're taken to the nearest emergency room, and that place may or may not be in network, and that's a real issue. So in this year's General Assembly, trying to figure out a way that we, one, protect consumers, that maybe the hospital is in network, but guess what? A group of doctors, the anesthesiologist or the pathologist or a surgeon, is not in network. Trying to make sure that we protect the consumer, protect the patient in that setting, and we're committed to working with the General Assembly to solve that.
Well, thank you for being here. I'm sorry we didn't have enough time to deal with the high cost of prescription drugs, but maybe at a later date. Thank you for being here, Dr. Daniel Cary. Good luck.
My pleasure. Thank you.
Thank you for watching Cable Reports, brought to you by the VCTA Broadband Association. Until next time, I am Woody Evans. Mm-hmm.